Dr. Mijatovic, welcome to the Tick Bootcamp podcast.
Thank you very much for inviting me.
I'm really excited to have you today. We have. We certainly haven't had many guests from your country, but we have had a couple of guests from Belgium. And you are affiliated with Red Labs or Red Laboratories in Belgium. So can you first talk to us about the company that you work for and give us a little history on the work of Red Labs?
Excellent. I'm a Chief Science Officer at Red Laboratories since more than 13 years. And Red Laboratories was founded 27 years ago by doctors involved with patients suffering from chronic fatigue syndrome and who couldn't find very specific testing on routine lab work. And that's why they found a lab who is at the interface of the research and diagnostic.
All right, so we're balancing research and diagnostic testing.
Researching the good markers and developing the tests to really fulfill the needs of the doctors for very specific testing in line with the advances in scientific literature. So, over the course of 27 years, of course, the science advanced and our testing approach advanced with it. We moved from only focusing on chronic fatigue syndrome to tick-borne diseases because tick-borne diseases were found to be one of the biggest underlying cause of chronic fatigue syndrome. And of course, tick-borne diseases, it's not only the pathogen. Well, we have extensive portfolio of tests developed for pathogen. It's also immune disorders and gastrointestinal disorders. So we very much focus on developing this vision of the integrative approach, first to have a very good test as best as possible for pathogen detection, but also not to neglect all immune disorders and gastrointestinal dysfunction that are unfortunately companion of tick-borne diseases.
Okay, so I'm really excited to hear that this is the approach that your lab is taking, because I think one of the challenges that most of the people in the Lyme disease community find to be frustrating is that in Western medicine, generally we're looking for one bug, one disease, kill the bug, resolve the disease, and very rarely do we see doctors focusing on terrain, our body's terrain. And it sounds to me that your lab is trying to strike the balance. First, you're looking at the research that's being done in the community generally. You're bringing that research into your lab to see if it can be replicated. You're then creating testing that is in line with the research results that you're replicating. And what you're doing is you're both creating tests to diagnose the disease or the microbes that are causing the disease, and you're also testing the terrain of the patient, both the gut terrain and the immune function of the patient.
Yeah. So what we try to do is first to develop the tests to detect the pathogens, and with this we have the exclusivity of Phage-Based Borrelia Testing, which is a very, very innovative approach of diagnosing Borrelia disease, because it is looking for bacteriophages and no more for bacteria. What are bacteriophages? These are viruses that are extremely specific of the bacteria. Each bacteria has its own virus.
Every bacteria has a virus?
Yeah.
How does that work? This is new to me.
Okay. It's very interesting because it also regulates bacterial population. If not, we will be completely covered by bacteria. So they have two life cycles. They have lysogenic and lytic. So lysogenic, they enter into bacteria, they replicate, they use the machinery, and they're in kind of symbiotic, let's say. And then all of a sudden, they decide to go to the sorry.
That's okay.
To the lytic cycle. They explode the bacteria, they go out in the circulation, and then they have to find another bacteria, because alone they cannot live without hosts. So they have to find their perfect host. For example, one bacteriophage from Mijatovic will be unable to enter Borrelia burgdorferi. one from herbicide cannot go to Mijatovic. So the idea is to look for those specific bacteriophages as a witness of Borrelia infection, knowing that a bacteriophage needs a living bacteria to live. So if you find bacteriophage DNA, you know that you have an active disease. And it's a really big step forward in diagnosing Borrelias with all those indirect tests that are looking for exposure, immunoblots, Western blots, serologies, ELISA, CFA, etc. This one is direct one. So the test is based on perfect combination that is evolving because we changed those couples of primers and probes that are covering the whole Borrelia panel. I have 3 designed for Borrelia burgdorferi insulato, 1 for Mijatovic, and 2 for Borrelia relapsing fever.
So it's three strains of Borrelia.
No, it's groups. Borrelia,
Groups?
3 groups, 3 major groups. You have what we call Lyme disease, Borrelia burgdorferi insulato, Borrelia Mijatovic, and Borrelia relapsing fever group. So in one test, you have them all. And if the result is positive, we sequence the fragment in order to be sure that the positive results is not a false positive. And this is also a major advance. So this is a fruit of a big research initiated at Leicester University and sponsored by Felix Charity, which is a French and UK charity. And then we took over with the means of technology transfer and further adapting and developing tests for laboratory use on a large scale. The test started with 1 primer probe, now we are with 7. And we follow the literature because all those bugs are mutating and you have to adapt your testing tools in order to be always able to detect them.
Right.
So we are very proud to offer this test worldwide. On the same technology, we have rickettsia testing, and we are working on Bartonella, but that one is really difficult. We hope to be successful in the future, but for the moment, we are still in the research. So we have this development of the tests for pathogens, and then we have the test to look at the microbiome and the leaky gut.
So let's focus on that piece now. So you have a series of tests for the microbes or the pathogens. Now let's talk about the gut and why that's so important.
Yeah, the gut is extremely important because over 85% of our immunity comes from the gut. And people usually forget this, but you really need to think about it. And gut health is something very important. First, if you have a good microbiome, you will better fight the infections. And I can tell you that since 13 years we are doing this test, we have in-house microbiome metagenomic test. I didn't see one good or let's say normal from a tick-borne disease patient.
Let's pause there for a second because that's one of the issues that we talk about on our podcast all the time is why so much of the immune system is in our gut, right? And one of the doctors we interviewed argued that the reason so much of the immune system is in our gut is because much of the outside world comes through our mouth and into our stomach, and every time we eat something, there are going to be pathogens all over everything that we eat, and our immune system needs to kill off the bad pathogens that are coming in with the foods that we're eating, and that's why a majority of our gut is there. Do you accept that as an explanation?
Yeah, and also you need a wide array of bacteria to be able to digest the food you take. And on last conferences, we had very excellent talks by Dr. Hazan, who is speaking also here, about the importance of bifidobacterium in defense and clearance of COVID and tick-borne diseases. So this is extremely important, keeping the gut in a good health, but not only the gut diversity, also to keep the gut closed, to avoid the leaky gut. Because if you
Let's talk about that. What is leaky gut?
Leaky gut is the fact that the cells of intestinal lining are not tightly one against other, and they can let the pathogens and macromolecules goes from the gut through to the blood circulation, and then goes a lot of side effects like sustained inflammation, toxin release that can go to the brain. Brain fog is something that is well known.
Yes, in this community for sure.
Yeah. And so brain fog is not just because they're fatigued. Brain fog comes from toxins, it comes from the gut up to the brain. They comes from bacteria, dysbiotic bacteria that are in the gut, that are releasing those, like ammonia, that are releasing those toxins that go up to the brain. So all this is extremely interconnected and super complex. So just clearing the pathogen, Borrelia, Babesia, Bartonella, it's important, but it's not sufficient. We see that this is not sufficient, and we had several cases of patients that have been cleared for pathogens, but still struggling with the gut issues for months, even years after the clearance.
So let's talk about that, because the one of the gut issues that we discuss all the time on this podcast is the impact that antibiotics have on your gut. So my question to you is, when you're doing your gut testing, are you doing that before folks are treated for the pathogen load, or you're doing that after, or you're doing both before and after as part of the?
It depends on the doctor.
Plan?
There are doctors who always do the baseline assessment. So say, okay, this is my starting point. And then they're doing periodically to see, because they're treating at the same time the tick-borne disease infections,
right,
and the gut dysbiosis or leaky gut.
So the best use of the test is to use it on an ongoing basis. You have a baseline, and then you're able to constantly test the gut to see what impact the treatment protocol is having.
4 to 6 months, at least twice a year, or when there is a major change. It's always personalized. You cannot make one fits it all.
Oh, of course. But we're trying to talk about best practices.
Yeah. On the other hand, you have doctors who said, okay, I will do the baseline, and then maybe I will do one after I complete the full therapy and wait 2 to 3 months to do it, because this is also a problem with the costs. All those tests are out of pocket. They're not reimbursed, and the doctors needs also to think about the possibility of patients to cover the costs.
Yeah.
Even if our policy was always to work with a very minimal margin just to cover our basic expenses, not to make money on it. But still, the reagents are increasing every 3 months,
of course.
And even with keeping the margins low, it's still expensive for patients. Or our goal is that the patients can take as much tests as they need. Is the ideal. In ideal world,
right.
We can never reach this, but at least we strive to it.
So one of the questions I always have when we're talking about gut testing is, what is it that you're testing for? Because exactly. I've come to understand that that our microbiome is where there's the greatest diversity in the human population. Most people think that we are genetically diverse, but as it turns out, we're not all that genetically diverse, right? I mean, we have 99% of our genetic materials in a monkey, and so there's not as much diversity in the genetic elements of humanity as we think there is. But our gut biome is very diverse. Yours is very different than mine is very different than Robert's.
Your might be very similar to the people who are living with you, because you have the same diet, you have the same lifestyle,
right?
With or without toxins, with or without very specific diet or very specific food that you can or you cannot, if you're gluten-free, casein-free, or all this are influencing your
For sure. So, but my question,
gut.
doctor, is what are you looking for when you're testing the gut?
So, you have on the market plenty of tests, similar, dissimilar. Our ones are focusing on the bacterial content.
Okay.
because we wanted really to go deep. You have tests that are testing a bit of everything, but it's a little bit of everything. And then at the end, you have like a helicopter view, but you might miss something. So we really try to go deep in bacterial, and if there is a need to do parasite testing, then it's a part. And if there is a need to do fungi testing, it's a part. So the big focus is on this bacterial content.
Okay. Now, you said the third element of your testing is the immune function.
Exactly.
Right? Now, can you distinguish, well, first of all, what is immune testing, and how much of that immune testing is based on the gut, and how much of that immune testing is based on your immune system generally?
So, to test immunity, you have to rely on biomarkers or on immune messengers like cytokines, pro-inflammatory, anti-inflammatory cytokines, on inflammation mediator, but not those that are used for classic infections like CRP, which can go up with Escherichia coli or Streptococcus. But you will never have a Borrelia patient with high CRP. Never.
Okay.
Then you have to go to more specific markers like prostaglandin E2, like hypersensitive CRP, to see the level of inflammation. And usually those markers are pretty high. You have to make also the reference range for this because these are not common tests. So that you can test for obviously what we know all, CD57, CD56 ratio to see, knowing that those factors are evolving, but correcting very slowly. Some patients are very disappointed because they said, I feel better, but my CD57 is still really bad.
Yeah.
It takes time to go up. Also, you need to think about interpretation, which sometimes people do not pay attention. If you had a recent CMV infection, or we see now with COVID, or herpes infection, your CD57 can be looking like normal, but it's false. It's because of the viral infection. Then we have a very nice marker linked to the gut. It's soluble CD14. The soluble CD14, it's the receptor for the LPS. So when you have gram-negative bacteria going with the leaky gut to the bloodstream, you will have obviously the LPS from the cell membrane, and you will have the shredding of CD14 from the membrane, creating soluble CD14, which will go to trap this LPS. So the amount of CD14 is directly proportional to the LPS.
Okay.
While the LPS testing is pretty bad, the tests are very much unstable. Those for CD14 are very stable. And you can really see the progress of clearance of this LPS with testing for CD14. So these are, let's say, the major tests that we do. We have a full range, but these are, let's say, the flagship test that the people do to assess the basic immunity.
I mean, it's very exciting. I mean, it's really very exciting to hear about. So, I have two more questions about the tests, and then we're going to have to wind down the short form podcast. But I want to invite you to our long form podcast that we do at Tick Bootcamp. But my first question is, what is the test like for each of the three major tests? Is it a blood test? Is it a fecal test? Is it something else? I mean, what do you need to test for each of the three major tests?
You need to think about what I'm looking for. For example, for the microbiome,
yes.
you will not do it in blood. You will do it in stool.
Stool. Okay, so stool is for the gut test.
For the gut test.
Okay.
But for CD14, you will have to do in the serum because it's serum protein.
Right.
For pathogens, it's mainly blood test, knowing that some of them could be also biops, because we do a lot of biops, skin biops. If you have the pathogens in bladder cysts or in ovary cysts, we can do all of them. So
that's pathogenetic testing.
Yeah, everything that is PCR-based testing could be done on any kind of biological material. Immune testing are obviously on blood.
Yes.
After that, you can do some urine testing also to look for toxins, to look also for pathogens, because there are pathogens that are excreted and you can trap them in urine. So you have variety of fluids that you can use. There are studies comparing also for the pathogens the different type of metrics like saliva, swabs, urine, blood components like serum, plasma, whole blood. So you can test on many matrices, including testing the ticks itself.
Right.
Which I'm really advocating for, and we do the brochures. We try to do awareness and prevention, to explain how important it is to keep the tick and to get the tick tested, because then you crush the whole animal. And you have, if your tick that was attached to you was positive, then you really have to think about.
Well, one of the questions I have with that, and we strongly advocate at Tick Boot Camp that part of your protocol should be not only to learn how to properly remove a tick, but how to both preserve the tick and send it for testing. But one of the questions I've always had in my mind about tick testing is, does the microbes that you find in the tick necessarily mean that it was spit into you, right? Because there generally is some gap in time between the time that a tick attaches and the time that the various microbes are ultimately spit into you. So is it possible that you might get a false positive on Borrelia for a tick that has only been feeding on you for 15 minutes, for example, when the tick itself had Borrelia, but it would not have been attached long enough to spit that into you?
The attachment time was always something that intrigued the scientific community, because it's very difficult to assess in human. It means that you need to have the tick attached, to take the blood draw every 15 minutes or something like this. So the most of the studies we have are animal studies.
Right.
So in animal studies, I really insist on this, there are studies now even demonstrating that some strains are transmitted within 30 seconds. So
30 seconds for some microbes, right?
Yeah. So the fact is, that we said before, it was not attached for 24 or 48 hours.
Yeah.
It does not. We have to forget about it.
I agree. I'm not a big fan of that.
To be on the safe side, I think the first step is testing the tick. If the tick is negative, okay, good, perfect. If the tick is positive,
well, but let me ask you about that. Is it possible that a tick could be negative because it's spit all the microbes into you already, and now when they're testing the tick, the microbes are already in you?
Theoretically, this is possible.
Yeah.
But it's pretty much rare, because they do not throw everything in you. Now, everything is in nature.
Right.
You can always make human testing after doing the tick testing.
Right. But they're all data points, right? I mean, I think what I've really loved about this interview that we're doing together is you're talking about different vehicles for getting data points that give you a better picture, right? Because what's happening with most people who are sick with Lyme disease is they're doing a tick panel and they're using that as the sole diagnostic tool, whereas you're arguing, look, we need to look at a lot more so we can get a better picture. We need to look at the gut. We need to look at the immune function. We need to look at the tick. We need to look at, and we need to do this regularly because it's going to present differently in you.
Exactly.
And we need more data. And your laboratory, Red Laboratories, which I'm so blessed to have met you today because I hadn't heard of before, has created this protocol that allows us to continue to not only begin with more data, but to continuously develop more data so that you can have a better patient outcome.
Exactly, and this is where we need to fill another gap, to have the doctors who are trained for this integrative approach, and not only focusing on one part, that they are able to tailor the testing package and the treatment package for every single different patient.
Yeah,
and this is the biggest
and that's how
challenge.
that's how we get to individualized medicine, right?
Yeah, exactly.
So how do folks work with your company? Is there any direct services that you can provide to the patient community? Or is
So
all
we
this through-
do not see the patients.
No, of course not. But I mean, can a patient
patients
go to a lab?
Yeah, they can send an email, ask for the details. So we have a very, very, very extensive website.
Okay.
Translated in 4 languages, and they can have a lot of information just by going and digging through the website, to the blogs that we are posting.
And what is the site? What is the name of the website?
It's redlabs.com.
Redlabs.com. REDLABS.com.
.com.
Fantastic.
You have it in English, in French, in Spanish, and in Dutch.
Okay.
And you have a lot of information there of what we do. After that, it's just to send us an email saying, okay, I would like to be tested with this, and this. Okay? Or the other road is to go through a healthcare provider, doctor, naturopath.
And encourage your doctor to work with a lab.
Yeah. And, or they can also send a message. Usually they call me because, among patients, they know to whom they have to speak. And they ask, okay, I have this symptoms for years. Do you have any doctor in my area or not so far that I can consult and who is working with you, and like this I can go with the testing. You have those who want first to get tested and then to look for the doctor. So we try to adapt. But the population that comes to us, there are 2 big populations, one big and one small. One big is the people who already went to 10, 15, 20, 30 specialists,
Yeah.
and they're desperate.
Yes.
So they come to us saying, really crying for help. And we have another community now emerging. These are the parents of kids who are bitten. It's kids who are developing autism spectrum disorder, because this is our third focus. It's autism spectrum disorders, which also have roots in tick-borne diseases,
yes.
of course, and everything. It's a vicious circle.
It is.
So we have this population of patients who are looking for, okay, my kid was bitten on a scout camp 10 times. I do what? So there are those.
It gives you the capacity to monitor how they're doing.
So we do the prevention with the people who are running this camp, trying really to sensibilize, to say, okay. So we are not really a classic diagnostic lab. We are much more global and much more atypical, but I'm really proud of this because we try to do also the education, the prevention, and not only the testing.
Well, I'm glad to have met you, and I'm really glad to have introduced you to the Tick Boot Camp community. I think they're going to just love you because you really are lovely, and you did a great job of describing all of these different options that folks have. And I'd like to follow up with you and do a long-form podcast with you sometime in the near future.
I'm really happy to do this.
Well, thank you.
Thank you.